So, good afternoon. I'm Eric Rackow. I'm a physician and, in my clinical and academic career, a critical care physician. Spent my entire career in academic medicine except for my time now with Humana as president of Humana at Home. So how did I get from there to here? Well, in the ICU, as you probably know, if you look at the patient population and you exclude younger patients that have major operations or are traumatically injured, you primarily have a population of seniors with chronic illnesses and exacerbations that bring them into the hospital and into the ICU. And it struck me one day that we're not going to solve this in the hospital. We're going to solve this outside of the hospital, which is what's been talked about at this conference. So, Humana at Home. Humana is pivoting from a health plan to a health company to create an integrated care model to support the people we serve, our members. If I could have the next slide. I'd like to tell you a little bit, I guess I can do that. I'd like to tell you a little bit about Humana at Home, the organization. We employ over 3,000 nurse and social worker care managers to telephonically care manage our members. We'll talk about that in a little bit. We have over 14,000 employed and network care managers nationwide so that we can scale in-home programs nationally, both ongoing care management and transitional care management 30-day programs. We have 60 home care agencies and are scaling that nationally. We employ over 3,000 home health aides in those home care agencies. And we particularly are proud of a national database that our care managers make available to our members to support them in their communities from various organizations that provide support structures for them, Meals on Wheels, audio books for the blind, etc. And we have an online portal to support families in their caregiving because we consider the family, a caregiver, as a key part of the care team, the care manager, the doctor, and the family. You see listed on this slide the key services we offer. We are currently managing 600,000 Humana members who are in either Medicare Advantage, MA SNP, or MA dual eligible programs. Our two core programs are the Chronic Care Program, which is ongoing care management for those who have critical needs, complex illnesses, multiple chronic conditions, and are in the top 25% of the most costly members of Humana. That is a telephonic program with in-home support when needed. About 25% of the telephonically managed members have an in-home visit to assess the home and circumstances. About 10% are in ongoing in-home care management. We surround our care managers and members with community health educators, social service support, behavioral management, interdisciplinary care team of nutritionists, pharmacists, and physician as a consultant to the care manager, so that in giving ongoing telephonic care management, we wrap support around that to make the program successful, which I'll show you some results on later. Our transitions program, and that program has about 400,000 members being managed in that program today. Our Humana at Home Transitions program is a national transitions 30-day program, very much like Mary Naylor's or Eric Coleman's program. It's in-home based, 3 visits, a visit to the hospital before discharge, a visit within 48 hours of going home and prior to the PCP appointment, arrange the PCP appointment, and visit after the PCP appointment to follow up. We have 30,000 members that have been transitioned this year in that program nationally. So our expertise is really care managing older adults with multiple chronic conditions, and especially when they have functional, behavioral, or cognitive limitations. This is Humana data. We target the sickest 25% of the Humana population that spend approximately 80% of the money. The top 5% at Humana spend 38% of the money. These These members all have chronic conditions, functional deficits, they've been to the hospital, and they're likely to be associated in the top 25% sickest moving forward. We risk stratify by a predictive model to identify these members. I always found this particular publication interesting from the Lewin Group. They looked at the same databases everybody looks at, but they sorted out disease and functional limitation. And you can see that the risk of being in the top 5% of the most costly patients in the country, and that's true for Medicare, Medicaid, and commercially insured people, increases as they develop more chronic illness, certainly, but more functional limitation. So if 1 is the baseline for the whole population, and you have 2+ chronic conditions, you have 2.7 times the risk of being the top 5%. But if you have 2+ chronic conditions and need IADL or ADL support, personal care with a home health aide, you have 7 times the risk. So we find that in our experience, functionality, or the lack of functionality, drives healthcare utilization and cost in the chronically ill, especially in seniors. And so we pay particular attention to physical, behavioral, and cognitive functional limitation in our members. And then we scale our programs accordingly. On the vertical axis, representation of number and severity of illness. On the horizontal axis, functionality. So as you develop more illness and you have more functional deficits, you need a higher level of support. Perhaps on the lower left-hand side, you just need telephonic coaching. Perhaps if you have a bit more disease and a bit more functional difficulty, you need telephonic care management ongoing to coordinate your care. Perhaps if you have particularly difficult functional needs, you need in-home care management, and ultimately moving toward in-home care, both medical and nursing care and hospital at home. So depending on the risk stratification of the member, we grade our level of intervention depending on the need of the member. Ultimately, we are planning to build a program that looks something like this pyramid. Building on our solid foundation of care coordination and care management, and using telehealth and remote monitoring to connect us to our members 24/7, we believe we can provide the kind of care support and care coordination our members need, especially working with the primary care clinician and working with the family caregiver. Then, as needs arise for personal care support, using our licensed home care home health aides to provide that personal care. You heard a lot about that in the previous panel. Using home health skilled services, which we're currently developing certified Medicare services in our home care companies by certifying them to provide skilled care in the home. And with doctor visits in the home to coordinate care, we intend to provide clinical care in the home. So we're pivoting from care coordination to direct clinical care of Humana members. And ultimately, building a hospital at home program. So even when we have acute exacerbations for appropriately defined individuals as identified by the expert Dr. Leff, who is here as co-chair of this particular conference, for appropriately identified members, treat them at home, given this pyramid of capability we have, connected by telehealth. So let me show you some of the results that we've had with our Care Management Foundation. On the left-hand side is the results of our program in 2013 for 116,000 newly managed members, pre and post care management, a decrease of 42% in admissions per 1,000. We've just completed the 2014 data with the same results. On the right-hand side is our pre and post results for 16,000 members transitioned from hospital to home in 500 hospitals nationwide, with a reduction of 39% in readmission. We've just completed analyzing 30,000 members in 2014, same results. So we believe a very strong platform of care management can change the health of people and keep them safely at home and out of the hospital, and by the way, out of the nursing home. So people will say, yes, you keep people out of the hospital, but is that the right thing to do? Do they really need to go to the hospital? Well, as a corollary to this, in looking at our data, in people who are care managed and have a decrease in hospitalization rate, a decrease in readmit rate, they have an increase in survival. So members in the Humana Chronic Care Program have a 2.8% absolute improvement in survival, a 26% increase in survival compared to unmanaged members. So we think we've got a very strong platform that you can demonstrate that care coordination and care management works, and we're in the middle of a paradigm shift, as everyone in this conference knows, from acute care to chronic care, from hospital to home, and Humana is going to move into the home to take care of the people that we serve. We're going to continue our care management program, which substantially reduces hospitalizations and improves survival. We're going to build a virtual platform for 24/7 connectivity with members and their families. And we're going to build a home-based clinical service, including hospital at home, to continue to provide care to those in most need. Thank you.